from the Healthcare Authority. I'd like to welcome all of you to the Health Innovation Leadership Network meeting. We're going to introduce those folks on the phone and review the agenda for today in just a moment. But first, before we dive in, we have to do the requisite housekeeping when we're trying to do a web meeting. So to ensure that we have active dialogue, we have unmuted every HILN member's phone line. If you are a HILN member and find that you're unable to speak, it may be that you need to dial back in or enter your audio pin. You can also send a message via chat as well, and we will support you in getting on the line. And because all of our lines are open, it's very important that you mute your own line when you're not speaking. And please do not put the call on hold. At any point, you can use the chat box, but I do encourage you to chime in as you see fit. We'll have several points during today's meeting where we'll pause for dialogue, and most of our last hour will be dialogue-based. Just as a quick note before I have the opportunity to introduce my co-chair, Bill Robertson, I want to just note that this is the first time we've done a meeting like this over webinar, so we're going to be adjusting as we go to make sure that we can, if you're not in the room, we can hear your voice over the phone and make sure that we can be as interactive as possible. But before we do the introductions via roll call on the phone, it's my privilege actually to welcome Bill Robertson, who's our new HILN co-chair replacing Rick Cooper. Just a few little notes about Bill's background. He is a president and CEO of Multicare Health System. He joined Multicare in 2014. He came here from Adventist Healthcare, Inc., based in Gaithersburg, Maryland. Is it Gaithersburg, okay. Prior to Adventist, Bill served as CEO of Shawnee Mission Medical Center near Kansas City in Kansas. He has a Bachelor of Science degree in accounting from Southern Adventist University and an MBA from Texas Christian University. He started his career as a CPA and an internal auditor, as he just told me. So we're really lucky to have Bill as our co-chair because he not only brings a wealth of health systems transformation experience and is a dedicated community leader, but he is also an active leader and accelerator of Healthier Washington. Multicare is actively engaged in efforts to integrate physical health and in the Pierce Accountable Community of Health, as well as in the state ACP for public employees. So in the short time that he's been in the state, he's really ensconced in all the work we're trying to do with Healthier Washington. So I'm going to let Bill talk a little bit more about himself, and then he'll get us started on our roll call. Bill.
My least favorite topic is myself, and so I will be very brief. It's a privilege to be a part of this group. I can tell you it's an awesome group of participants, and I just consider it a privilege to be invited to participate here. I love being in Washington. My mother actually was from Tacoma, although I didn't really know that until I moved out here, which is kind of odd. But growing up, there was in my mother's house always this picture of a mountain. I didn't know what that was until I moved out here and realized it was Mount Rainier. So I feel very much at home here, and it's a privilege to be a part of the healthcare community here. I thought maybe the best way to introduce myself is to just give you a little snippet of how we're looking at this topic that we're talking about, but Healthier Washington inside Multicare Health System, with just two little snippets of ideas that we're working on. The first is that we have concluded that we don't get to define as a healthcare delivery system as what the value needs are of those we serve. And so we're looking at value, trying to look at value through the eyes of the people we serve, not just our patients, but the people who pay for care, the people who collaborate with us around care, and the people who regulate us, and a whole does. So we think there's 5 basic customer groups. So that's one idea that we're working on. The other is that we are firm believers in the triple aim, but we think there's a couple other things that have to be a part of that. So the first is that if we don't have a viable, vibrant, engaged group of providers in the delivery system, that's a problem going forward. So we've added that to our list. The other is that we actually think the delivery system and the infrastructure that we work in collaboration with has to be viable and sustainable itself. So low cost and having no delivery systems would be kind of a bad outcome. And so we're focused on that. And the third is we think health equity has to be a part of the conversation. So that's just a sense of how we're thinking about creating the future. And it maybe gives you a sense of where I'm coming from as a leader. I do see the world from a servant leadership perspective and hope to exemplify that in my work. So thank you for the opportunity to be of service here. So I'm going to move from that introduction to making sure we know who's on the phone, and I'm going to go through the list of people we believe who are on the phone or are present here, and then if I've missed anybody, we'll open it up for people to identify themselves on the phone. So I'm going to give name and the organization that you represent. So we have Peter Adler with Molina Healthcare, and actually he is here. I saw him here a few minutes ago, and I just see him now. And I apologize if I don't say the names well. I'm still learning these. So Teresita Batiola, International Community Health Services, Nicole Bell with Cambia Grove, Diana Burkett-Rakow with Group Health Cooperative, Ann Christian with the Community, oh yeah, that is not Group Health Cooperative, Kaiser Permanente. So Ann Christian with Community Mental Health Council, Regina Delahunt Hunt with Whatcom County Health and Human Services, Michael Erickson with Neighbor Care, Nancy Gento with Washington Health Alliance, Mike Kreidler, and Lonnie Johns Brown with the Office of Insurance of the Insurance Commissioner, Pam McEwen and Molly Voorhees with Health Benefits Exchange, Peter Morgan with the Family Health Centers, Steve Mullen with Washington Roundtable, Diana Narasaki, Asian Counseling and Referral Service, Lisa Rakoz, Office of the Superintendent for Public Instruction, Joe Roszak, Kitsap Mental Health Services, Bill Rumpf with the Mercy Housing Northwest, Jill Sells with the Reach Out and Read Washington State, Diane Sosny with SEIU 1199 Northwest, Jurgen Unitzer, University of Washington Department of Psychiatry, Janet Veron, Northwest Health Law Advocates, Ron Vivian with Washington State Council on Aging, David Wertheimer with Gates Foundation Pacific Northwest Initiative, Carolyn Wallen and Gina Morgan with King County, and John Weissman with the Department of Health. So that's who we think we know. Who else might be on the phone or in the room who's a member of the HILN? We've got everybody. Okay, excellent. Well, thank you for joining. That's a great turnout for the first online conversation. So what I'd like to turn to next is what are our objectives for today's meeting. We actually have three straightforward objectives. It may not be straightforward by the time we get done, but we think they're pretty straightforward. Today's meeting progresses our focus on spreading and sustaining the Healthier Washington vision and strategies. HILN will support an action agenda this year to advance Healthier Washington's goals. And these are really interesting goals. 80% value-based payment in state finance contracts by 2019. That seems like just about a year and a half away. With an interim goal to hit a 30% value-based purchasing by the conclusion of this year, as well as our goal to have 50% of the commercial market in value-based arrangements by 2019. So those are real tangible goals. So that's one of the things that's what we're working towards. We ask all of us, some of us did better than others. I must admit I did not do this as well as I should. We asked you to complete pre-work, which many of you did. We'll review those commitments as well as garner 2017 actions to advance value from those who were on the phone today and in the room. Our objective by the time we conclude at noon today is to agree to a collective action agenda comprised of individual HILN member commitments to action and have a clear path forward with regard to who will do what by when and how we want to work together to monitor and advance the work we're doing. This action agenda builds to an October Healthier Washington Symposium, during which we will share our commitments to an action toward value and ask other partners and leaders across the state to join us in action. So continuing with our, just a brief outline of what our agenda is today. This agenda was sent out. It was, I thought, very well crafted to create a conversation, because that's what we're hoping to get to today. The materials were sent out last week from an email from Dorothy's inbox. Let me go through the agenda just briefly here. First, Dorothy's going to do some level setting and talk about our proposed HILN role for the next year. We'll have some time for discussion with a particular focus on sharing what value means to us, and us comes from different perspectives, so it's just going to be really interesting. Nathan Johnson, HCA's Chief Policy Officer, who also ran for president last year, I understand, on the alternate Republican ticket, will provide a brief update.
Those are alternative facts you're looking at.
We'll provide a brief update on Healthier Washington efforts and activities, some time for questions and dialogue from the group. And then the majority of our time, which is close to an hour, will be spent discussing our specific commitments to value. We'll review the pre-work responses and ask all of those who are in attendance here today to commit to one action to advance our value-based goals. At this point, I'm going to turn this back over to Dorothy to discuss the HILN's role this year, advancing value-based systems. So, Dorothy.
Great. Well, thanks so much. And just as you were talking, Bill, Peter Rutherford also joined us.
Great.
So welcome, Peter. Okay, so this should be a familiar slide to many of you, but I always find it really helpful for myself and hopefully others to do this kind of fundamental level setting about Healthier Washington as we go forward, and to sort of carry on the messages that Bill started us with. Remember that the Healthier Washington strategy really embodies our commitment as a state, from the governor through all of us, to improve the health of our people and of our communities. And we're doing that with, we've kind of boiled it into 3 core strategy areas or domains to advance the interrelated aims of better costs, better care, lower costs, and also healthier populations. I also want to note the ones that Bill added as well in terms of viable and thriving delivery systems writ large, as well as making all the work that we're doing fun to work, and people want to stay working in the Healthier Washington environment that we have in the state of Washington. So just to reiterate and review these 3 domains, one is paying for value and outcomes over volume of services. I will say that the state is being recognized at the national level for the work we're doing in this area, and this is really, if we don't do anything else, well, we've got to make sure that we're using the dollars that we have to really drive with our partners the best way to deliver the best outcomes that we want. So moving to value over outcomes. Secondly is ensuring that care focuses on the whole person, with a specific focus that we've spent quite a bit of time with learning about over the last several months with HILN, a specific focus on physical and behavioral health integration. And finally, recognizing that health is local in many ways, and producing healthier communities really requires regional collaboration. So even while we have a state strategy, we really need to ensure that within each region, the things that make most sense in those regions based on the assets that are there are available. We do have multiple implementation mechanisms to transform payment and delivery of care for the entire population of the state. Obviously, we all remember the foundational legislation that got it started, the $65 million federal grant from CMMI that we're, believe it or not, halfway through that grant period. And then a new Medicaid transformation demonstration to advance our strategies and goals specifically for the Medicaid population. And so keeping in mind the idea that we have multiple strategies, and we can run the risk if we don't come up with a real coherent map of how we put all this together, to have a whole bunch of things going on without it all being kind of tied together and connected into a transformed system. So you all know that we've been working really hard within HILN to create sort of systems thinking about what we're doing, and through that deployment of multiple innovations and with your partnership and action, our health system is starting to look different and will look even more different a few years or 5 years from now. Shifting from a system that rewards volume for services is fragmented and really doesn't serve our people and their families, as well as one that rewards outcomes for quality and cost, as well as serving the whole person and along the way. I think that the other words that we've been learning to use in a much more meaningful way is the concept of person-centered care and equitable care delivery. So those are all things that I think we can thank this HILN group as being key in terms of helping us frame up what those words really mean, instead of just being rhetoric. We've come a long way as a state. We have further to go. And so as we've been thinking about HILN, as we're moving into the next few years for HILN, trying to get much more concrete and deliberate and collaborative over the coming years will really help us move from that current system that we have, which I would say we're kind of in the middle. We're not at the current descriptor, we're not at the transformed system, but we're moving that along the way. That we'll have to use HILN to demonstrate the transformative, lasting changes that require both the public and private sectors to work together towards mutual goals. And before I go any further, I just wanted to also welcome Hugh Straley and Aaron Sparks to the conversation. Okay, so where we've been and where we're going. As I noted earlier, we're partway through at least our initial 5-year plan for Healthier Washington. Obviously, we're moving that forward even further now with the transformation project that we've got underway with Medicaid. But I think what we're really focused on, and based on the feedback from all of you, is to move from, as Bill so nicely put it this morning as we were talking, moving from more of the rhetoric and the vision to the actual results. And Nathan in a little while is going to tell us kind of where we are overall on that pathway. But we're really wanting for HILN to focus with us on the role over the coming years of spreading and performing and then sustaining the work that we're doing. So now that we've gotten all much more familiar with what the strategies are, what the building blocks are, we're thinking we're all ready to move forward in moving as accelerators in a more concrete way. We've been asking you all to accelerate Healthier Washington efforts along the way, and we've been doing that through your suggestions around storytelling, sharing the work that we're doing. But now we're shifting in 2017 to an advanced acceleration role for HILN. So today we're going to be focusing on even more concerted ways of spreading and sustaining the Healthier Washington strategies and vision. So as we've been talking this morning and throughout the last couple of years, a key lever in sustaining and spreading our success will be the ongoing leadership of HILN to commit to value, and specifically to support an action agenda to achieve Healthier Washington goals of 30% value-based payment in state finance contracts by the conclusion of 2017, progress towards our 2019 goals of 50% value-based payment in the commercial market and 80% value-based payment in state finance contracts. So we are going to have the opportunity in a few minutes to review the commitments to value and action that many of you sent us in advance of the meeting. Thank you very much for doing that. We've really appreciated that. And this word cloud that you see on this slide is the actual word cloud taken from the work that you all sent us in terms of what your intentions are to help us going forward, help the Healthier Washington going forward. So first of all, we have a couple of questions. We're going to have about 10 minutes for some dialogue here. And the questions, first is, our 2017 charge to advance value-based outcomes clear, and what more information do you need at this point to commit to that? And then also we asked you to tell us in the pre-work what value means to you, and here, as I just mentioned, are the words that represent this here. So this is our first attempt to have a dialogue over the phone and in the room. We're going to be having fun doing this, I think. We've got a lot of people that are ready to contribute. And I think what we're going to do to start is just to ask David from the Gates Foundation to comment a little bit more on what value-based healthcare means in the community to him. He has noted in his response that access to a comprehensive array of high-quality health services, fully inclusive of the supports and services associated with social determinants of health and educational attainment integrated into ACH visions, are really important, and to make sure we have those. Diana from Kaiser said value is the delivery of affordable, effective, high-quality, customer-oriented health solutions in Washington State. And Teresita from the International Community Health Services said that value is defined in the following actions or outcomes: reduction in emergency room use, elimination of redundant, non-evidence-based treatments, improving health of patients with overall wellness, and decreased costs, improved outcomes, and increased satisfaction. So those are some of the things just to get us started here with the question that we wanted to pose, which is our charge for HILN to advance the value-based outcome agenda clear? And is there any more information you need or clarification to help us move forward with that? And you can either raise your hand on the web portal and we'll call on you, or you can just speak up and we'll say your name when you're starting so we know exactly who you are. Diane Diane Sosny has her hand raised. Yes.
Thank you. So I'm not sure I heard, obviously we don't have the benefit, I think, of seeing everybody's write-up, but that health value means health equity. So regardless of race, ethnicity, gender, sexuality, religion, zip code, that people get care in a culturally competent manner, integrated with local community services, and that there are not financial barriers to seeking care.
So that's interesting. The last piece you said that is really important is the financial barriers. They're all important, but if you think about financial barriers for people to access services, making sure that as we also transition to value, that we're making sure that our mechanisms for delivery are viable as well, right? So it's a combination, but the health equity, cultural competence, and access to services with no financial barriers. Okay, those are great adds to this. Any other thoughts or comments from folks on the phone?
I was wondering if after you talked about where the current at and the goal is for 80% by 2019, I was wondering where we're at and what's the mechanism to measure progress over time.
So the question from the room was, where do we have data on where we are literally right now with meeting our goals for the 80% value-based payment, and how we're measuring that. I'm just checking, is that something that Nathan, I think, is going to be speaking to in just a few minutes? It's one that, just as a point of interest, is of a conversation going on nationally as well as here, is how you actually define that. So Nathan can speak to our progress today. We're making some progress, but good question. It's another one of those measurement questions, right? Yeah, Stella?
Peter Morgan has a comment.
Okay, Peter Morgan on the phone.
Well, I think that last question kind of covered it, but to me, value is some outcome for a certain price. And I think, we need to move down the road of measuring, what our outcome is for the money spent. And as we talk about measurement, let's not lose the public health outcomes. One of the things that I focus on in Okanagan County is the Robert Wood Johnson County Health Ratings, and they may not be the right measures, but ultimately, we have to figure out what's the total spend. Is it the government spend? Is it everybody's spend? But I think it's probably the aggregate spend for the outcomes, and I want to make sure that the public health outcomes are in there.
Okay, Peter, can you just, for the sake of the room, come up with at least one of those public health outcomes that you're thinking of? I think it's a really important point.
Well, I think for that that measure of county health, it's ultimately something like unnecessary lives lost, or I'm not sure what the measure is, but it speaks to life expectancy, at least not shortened unnecessarily by a whole host of factors.
Yeah, so maybe the quality life years lived, something along those lines. That's a great idea.
Yeah, well, I mean, there are things in there like, teen pregnancy rates and employment rates and homelessness rates, all those things impinge on health and vice versa. So let's make sure that we walk the talk about social determinants.
Okay, great. Thank you. Any other comments or thoughts from people on the phone?
Dorothy, Michael Erickson here. I was just struck as I read through everyone's comments that there is a considerable alignment and agreement around what value means here. I mean, there's different emphasis in different documents, but it's quite striking that the group that's here already has a pretty clear idea what value means, and that was impressive.
Yeah, I had that same kind of reaction when I saw just even the word cloud and then some of the specifics that have been mentioned so far. Okay, I don't want to belabor this if there are no other comments or thoughts on this.
Dorothy,
we're gonna have yeah, go ahead.
This is Joe jumping in. Just I texted it in, but I'll voice it in. That value is looking at a focus on outcomes, treatment outcomes, not just the volume, and that the outcomes that we choose are meaningful to the patient and also the provider and payer and the community as a whole. And then the second part of that is a process piece, which has to do with I would add, has to do with the reducing the administrative regulatory weights or that often encumber the achievement of outcomes. So you want to be efficient and effective.
Yeah, so that's actually a really good point, that wherever we can get rid of unnecessary activities, whatever kind of waste it is, including regulatory, we can, as a group, think about who's here. There's a pretty big opportunity to do that.
Yeah,
okay.
This is Hugh Straley. I want to second that about we've mentioned the triple aim plus social determinants, but also efficiency and the quadruple aim to reduce administrative burden, because we've heard loud and clear from the clinical community the need to reduce the burden and have focused outcomes and measures rather than a dozen different measures from a dozen different health plans.
Yes, that's and Bob Perna is in the room, and I know he's a partner with all of us on looking at that from the perspective of some of the transactional costs that we have in our current systems that we could be deleting or eliminating. Okay. Yes. Oh, Peter Adler is in the room. Yes.
I just add, building on the comments that people have emphasized, that the goal is not about value-based payment, but it's about outcomes, doing things which achieve health outcomes, that there's a temporal piece that
going to repeat what Peter said because I'm not sure, unless, can people hear on the phone? I don't think so. Okay, Peter's making a really important comment here, and you know, as we start shifting our language to outcomes, we all have to learn as we go, I think, about what those really meaningful process measures are along the way that get us to those outcomes, because and that the outcomes take a longer time than just a year or two. So keeping in mind as we're doing our measurement of progress that those process outcomes that we choose to monitor our milestones have to be meaningful relative to the long-term outcomes that we're aspiring to. So to be patient with ourselves, but also remember that if we don't continue along this road, we'll never get to those outcomes that we're thinking of. Okay, thank you. Any other final comments? We have more time for dialogue as we go forward. I want to make sure that there's no other burning comments right now.
I'd like to ask a question. This is
yeah,
Bill Robertson. So I'm still really new to this, like, 30 minutes in. So, so my question is, we're really clear about the metric that we're moving towards how care is purchased, so 30, 50, 80%. And then we have words that describe the more qualitative aspects. Is there a journey we're going on to identify a subset of these qualitative things and turn them into quantitative metrics as well that we're working to achieve?
So I think so. Let me just say that is, I think, a fantastic question and one that we really need the help of the folks here to help us with. And maybe as we get to the, if somebody has like a really good response to that right now, we should take it. And if not, that's really a tee up for our last 45 minutes, because to me that's the most important question that we have. So can you guys all hold on to that question, because I think what Bill's saying, building on what Peter said, is if we're trying to go towards outcomes, there's a danger in just using broad terms without knowing exactly how we're going to measure our progress along the way. Is that what you're saying?
And it's not just that we have 80% contracts.
Right. It's what's in them.
Yeah.
So okay, that's a really key point. And let's come back to that one when we get to the last section of this, because probably where we can get a lot of our really good input is on that question. Okay, so Nathan, I'm going to turn this over to you. Nathan Johnson, you all are familiar with Nathan, and he's going to do an update of where we are since January, when we last met.
Has it been that long? Time
Yeah.
flies.
Well, and you lost the election, so you know.
Oh yeah, that's right. I must say that was being on the ticket like that. No, a lot of folks poked fun at me for that one. It turns out there's thousands of Nathan Johnsons in the world, though. What we're going to do for today's update is slightly different than what we have done before. Certainly there are programmatic features of Healthier Washington that we want to catch folks up to speed on in case you haven't been following all of your feedback blasts. We try to pile a lot of information out there. I hope folks do find it useful. So we do want to offer a few highlights, but before going down that path, wanted to set a construct, which I think we introduced, if I'm not mistaken, at the January meeting, and that is the goals of Healthier Washington. There's 9 of them that we have at the midpoint of, in particular, our state innovation model grant work, really come around understanding that there are specific projects, specific programs that map to many of these goal statements. But in thinking of Healthier Washington, as it was just indicated, as a much longer journey than what a 5-year demonstration might afford or what a 4-year grant might afford, we want to make sure that the goal statements are clear for this work and that the work itself actually maps to those goals. I won't belabor the point too much, but maybe we'll give you the shorthand of these goal statements for those of you tracking here in the room and on the webinar. The 9 goals are simply stated: supporting communities, spreading value, empowering people, supporting providers, rewarding high-quality care, ensuring whole-person care, sharing data, using that data and sustaining access over the long term. We think these 9 goals really capture Healthier Washington and certainly map to the 3 fundamental pillars that Dorothy was sharing earlier. And now I kind of want to discuss what programmatically has been occurring within the Healthier Washington program writ large to address and to achieve these 9 broad goal statements. The first thing that was really fresh in view in our January meeting, but has certainly moved since the January meeting, is the Medicaid demonstration. This is a phenomenal tool targeted at the Medicaid population and providing significant support up to $1.5 billion over the next 5 years. So since we met in January, our Medicaid transformation team with many, many partners has begun the very earnest work of standing this up. Year 1 of this 5-year demonstration is very much a startup and ramp-up year. We have of recent contracted with Manat Health Solutions for some of the initial support to the state and to our accountable communities of health who are driving the incentive payment program under Initiative 1. Even as we start to bring to scale from a design and implementation standpoint, the 2 service-related initiatives addressing long-term care and housing and employment needs of the populations we serve. Even with the turnover of administrations and some change in key staff at CMS, things are moving forward. Good discussions are indeed happening, and we expect very soon some very key approvals from CMS of protocols which form the programmatic details for this demonstration. But importantly, I think what we're watching as this demonstration comes along and as it comes along underneath the Healthier Washington umbrella is real momentum and real energy at the local level where the work actually needs to occur and has to occur for it to be sustainable. So that's been very fun to watch, and I know and recognize how many of you joining us as HILN members today have been key participants in driving this work locally and as well assisting us with our efforts earlier with CMS. Another key development that's actually occurred since we last met in January is in one of our payment models, Payment Model 2. To remind you all, there are 4 payment models. We don't have time to do a deep dive today on all 4, but an exciting milestone was reached with Payment Model 2 and our work with federally qualified health centers and rural health clinics. Although our payment models are not state purchaser-centric or Medicaid-centric by any means, Model 2 really has been focused on the Medicaid, some key Medicaid safety net partners who today, if you're a federally qualified health center or rural health clinic, really receive payments strictly based on encounters. This is how it has been formed in federal statute. There are very key financial protections attached to that, but nonetheless, it's very limiting for a clinic setting that wants to move integration forward, wants to bring a broader care team on, but is really penalized for creating any efficiencies in how they're delivering services. So the milestone that was reached is just several days ago, we received memorandums of understanding from 16 of our state's federally qualified health centers as well as 1 rural health clinic to advance this payment model with an implementation date of July 1. This has been a long time coming, and because one of our key staff is not here today, I should recognize him nonetheless. Gary Swan has been leading and guiding this work for nearly 2 years, and I want to also recognize Andrew from the Hospital Association, who's been a member of that working group and assisting along the way through that, I'll call it arduous and long-standing process. Much more work to come.
A long and winding road.
But I'm probably going over my 7 minutes. I do want to say, though, that the uniqueness of this payment model is it's converting those encounter-based payments into a per-member, per-month payment to clinics that is tied directly to quality improvement. That is to say, clinics still receive the federal statutory protections that ensure a base level of payment, but are incentivized as they bring on additional efficiencies within their system. They're able to actually receive more money than they would under an encounter-based system when they can demonstrate quality improvement. So we're really excited about that. And I think, Michael, we may want to put you on the spot later to talk about this payment model from a clinic's perspective if you're all right with that.
Yep, can do.
Thank you so much. As well, the work of financial integration, again, focused more so on Medicaid in this case in 2 regions of our state, Southwest where it's been implemented and North Central where it will be implemented in January of 2018. moves forward full steam ahead. Additional procurement and contract activity has occurred since January, and as well, significant additional interest from other regions has been generated for coming into full financial integration sooner than 2020. We expect to see by the next time we meet as a group binding letters of intent from at least 3 additional regions and perhaps more. And again, I'm thankful to the folks on HILN who are advocating in your respective regions of influence on that subject as we move forward. As well, the work of Qualys in standing up the Practice Transformation Support Hub has really moved forward in earnest over the last several months. Many providers are now signed on to that support structure, and it is dispersed throughout the state with still more ramp-up activities ahead of us. The interactive community checkup website hosted by the Washington Health Alliance was also stood up relatively recently. Incredible resource for folks who want to interact more so with the common measure set that defines value, really so far at least, for the Healthier Washington work, and I encourage everyone to make use of that. As well, I think I provided a precursor update in our last meeting, but with regard to the Accountable Care Program for state employees, our enrollment increased in the 2017 plan year by nearly 50%, and we expanded geographically to another 4 counties. We continue to see enrollment increases and are very appreciative of the partnerships formed with our 2 ACP networks to move that forward. Importantly, what's also exciting about that and an undercurrent through all of this work is leveraging things that have pre-exist actually, the formal Healthier Washington era, like the BRIE Collaborative, which is such a unique organization in the country, through which, for instance, its care transformation suggestions in a way have been implemented in our Accountable Care Program contract. As well, the BRIE Collaborative set forth bundles, several bundles that it has approved. We have implemented as a state purchaser in PEB the first total joint replacement bundle with a key delivery system partner, and are just released an RFI for additional bundles, which we anticipate implementing in early 2019. There are a few other things that we could update you on, but the thing I will land on today is later this afternoon we will be formally launching our Medicaid Value-Based Action Team. It's actually the MVP Action Team for short. We love our acronyms, and we wanted to have a little fun with this one in truth. This is focused on Medicaid value-based payment activities, but is also focused on the topic that we were just discussing, adding more definition and more concreteness to the work of advancing goals in the Medicaid book of business that actually expand and build upon what Healthier Washington has set us on a course on, actually trying to achieve 90% of the Medicaid business in value-based payment arrangements by 2021, 2 years following our 2019 goal that exists and pre-exists the Medicaid transformation work. So long story short, despite federal uncertainty and even preliminary action by a certain congressional body yesterday, our work in Washington State continues in earnest, and really it must continue in earnest, I think, from all of our joint perspectives here. So with that, I think I'm going to turn it over now to any questions folks might have in regards to the Healthier Washington efforts that I briefly described, or ones I may not have that you would appreciate a further update on or further discussion on at this time.
Yes, Nathan, this is Hugh from the BRIE. I have the question about what is the total enrollment so far for the ACP programs, and what is the expectation or goal for enrollment?
I'm so glad you asked. I should have actually defined my denominator there. 15,000 is how many employees and dependents are now enrolled actively as active participants in the ACPs. But what's also true is another 25 to 30,000 individuals are attributed to those networks. And so the networks are still able to manage care and receive financial incentives for those additional populations. So in total, upwards of 40,000 PEB members and their dependents being impacted by that particular effort.
And we will, from the BRIE, we will be very interested in how the recommendations are implemented, and really looking at the quantitative information about bundles and the other recommendations. So whenever that information is available or accumulated, we would really like to have that data.
Thanks for mentioning that, and I think I'm looking at our team. We'd perhaps like to work with Dan Lessler, our Chief Medical Officer, a little bit, and maybe provide a report back to BRIE on how those implementation efforts are going in the ACP networks, as well as perhaps an implementation update on the TJR bundle, total joint replacement bundle, that was just implemented.
Perfect.
Nancy?
So Nancy Jensen from the question I have stems from a meeting a couple of us were in earlier in the week where King County Executive Dow Constantine has put together a group of folks to think about the impact on King County of all the changes in D.C. And my question is, with the Medicaid waiver that I understand must get renewed annually, are any of the legislative changes that are currently happening impacting that? How safe is the waiver? Is what I'm trying to ask in short here.
And Nancy's question, for the benefit of those on the webinar, is in essence, how safe is the Medicaid demonstration with any federal changes or legislative changes that are moving forward? Nancy, the way I would answer that severalfold. One, it actually is unique from the State Innovation Model Grant, which is an annual cooperative agreement that has to be approved. And so far that has been smooth in terms of the administration turnover. With regard to the Medicaid demonstration, it is a binding 5-year agreement on both sides. There are really specific out clauses that have a significant threshold attached to them for either side of that deal would they want to retract from it. With regard to some of the major Medicaid financing proposals that are included in the bill that passed yesterday in the House, in the federal House, we would want to engage that discussion, in particular if our financial situation on the demonstration could even be improved with regard to any of those changes. Naturally, we're pretty concerned, and I think the governor has made that very clear, what kind of catastrophic impacts those Medicaid financing changes could have on the program. But of course, we would want to revisit the demonstration financial component if any major changes were made federally. I think what has been good to watch even over the last 24 hours is that the Senate doesn't seem overly taken with some of those major changes to Medicaid financing that would cut, I think, over $800 billion from the program. So we'll continue to track with all of you. Bottom line, we do believe the Medicaid demonstration is protected from any future changes of that nature. Bill Rump, I think you indicated you might have a question on the webinar. We may be unmuting you still, or I think you are unmuted. Bill, I think you're self-muted. Can you unmute yourself, potentially? Or I can make up a question for you, too. That might be fun. Or, Bill, if you want to type something out, too, that would be fine, and we'll address it. Other questions in the room or on the webinar? What's that? Oh, sorry. Hey, John Weisman, you have a question.
Yeah, I was just wondering if you could address how, from a leadership and management perspective, the SIM and the demonstration project are being integrated or not, and what for HILN do we want to sort of be paying attention to, or what's our role in sort of the demonstration piece?
Very, very good question. I think what I'll go back to, I don't know if we want to go back to the slides, actually. We actually consider the Healthier Washington goal statements that you see up there, and then as well the deliverables associated with Medicaid transformation as completely aligned. And in fact, in our own, just to go into the project management component of the question you just asked, all of the Medicaid demonstration work streams and individual projects associated are being mapped to these same goals, and our completion of them is being tracked in accordance with that. As well, internally to the Healthcare Authority, and John, I'm aware of activities similarly so in the Department of Health. We are organizing our own teams to not be siloed based on fund source for the activity, such that there is obviously so much overlap between Medicaid demonstration objectives and the Healthier Washington supportive structures that already exist. So we're being very careful from a project management, staffing, as well as sustainability planning standpoint to ensure that these things, both by this group and by the kind of our broader external stakeholders, are seen as very complementary to each other, but more than that, seen as part and parcel of the overall Healthier Washington initiative. So I suspect as the demonstration process matures further, we're going to need to do continued work on that. And then in particular with your question around the HILN group, our intent always has been for Health Innovation Leadership Network to be engaged and to be partners and accelerators in the work of Healthier Washington broadly. And we see that absolutely applying to the Medicaid demonstration and work ahead of us in that way. And also appreciate, in fact, some of the overlap that has been achieved between HILN membership and the MVP action team that was earlier referenced. And HILN members, of course, are invited to participate voluntarily. So in some of those more focused value-based payment discussions on Medicaid that are ahead of us over the next several years. Yeah. Thanks.
So this is Diane Sosney with SEIU Healthcare 1199 Northwest. Under rewarding high-quality care, is there anything about use? This has to do with the pharmaceuticals, and since they are such a major driver of cost, and when we think about value-based purchasing, I hear a lot of talk about best practices around knee replacement or fill in the procedure, but does it include use of generics, and what other ways are we addressing getting a handle on that, given that we were not, I believe, both successful this year in the legislature on some initiatives we were working on?
Diane, great question. And the question, if folks couldn't hear it as well in the webinar, is what about prescription drugs in terms of the value equation, both in terms of costs and utilization, for instance, of generics? One thing I might do, and Nancy, help me out here, but I'm pretty sure generic utilization rates are a measure in the common measure set. Am I remembering that correctly?
I was just actually trying to recall.
I think they are.
Yeah,
the fill rate.
I think we were doing very well on
We
the
are.
dialogue about whether to continue.
And Peter can speak from a Medicaid payer perspective that I think we are one of the top performers in the country in terms of our generic fill rate in Medicaid.
That is correct. We are today doing so well at the state on the generic fill rate, and any initiative which would threaten that it would be to everyone's detriment from a cost perspective.
And the one other thing that I might mention is the work that is underway and has been for some time now between our clinical team and some technical assistance support from OHSU, examining what value-based payment directly with prescription drug manufacturers might look like. That is, I would still say, in the very early and exploratory stages. Throughout the country, that is the case. But there is an active discussion happening even in our own state on that topic that was really born out of some of the summit series that our CMO and team hosted over this last calendar year. So there is discussion happening, and at least in part, we're tracking this both from a cost of care and utilization perspective.
Yeah, and if I could just add that there's at least two things that I'm thinking about, and maybe more. One is, it's great that we're doing very well. We should continue to do that, and even though we're better than other states, let's say, we should keep pushing to. So I think that's an important thing to be called out. And the second thing has to do with the, what we had seen over, I think, the last year with some of the EpiPen and diabetes medication in particular, where the manufacturers, the drug industry, just totally went nuts on raising prices. And what can we do in terms of this work statewide in helping to shine a light on that and try to influence it?
Sure. Well, and one other maybe activity that I could reference just of personal interest is I have the privilege of serving on the NASHP task force on prescription drugs, which is looking at both issues of transparency. In fact, was able to share some of their model legislation out of that work for folks that were interested in this year's session activities. They're also now turning their attention to another popular topic, but of reimportation, and so there'll be more potential coming from national discussions on this, that for folks interested, I can be a conduit at least of information if you would like. So,
NASB.
sorry, National Academy of State Health Policy. I apologize for. Is that I hope that's my only acronym screw up so far today. We'll keep it at that. We have, I think, time for one more question. And Teresita, I think, Teresita has her hand up, and go ahead and ask your question, Teresita.
But she did write in her question, will HILN develop guidance for criteria for the ACH demonstration program?
I think the question from Teresita is, will HILN develop criteria for ACH selection of demonstration projects? And Teresita, I'm sorry that it appears that you're muted on your end, but would like maybe like you to clarify the question. I'll try to answer it in the way I can. There is a project toolkit document that has been created with significant comments, public comments, stakeholder comments infused, that is now posted on our website and really is the menu of projects that will be available to ACHs to select from for purposes of the Medicaid demonstration. And there will also be in the July timeframe the release of a project plan application document, a template that ACHs will need to follow for submitting their projects for ultimate approval, and then of course the incentive payments that are tied to that. As a reference for those who haven't been as closely following this work, there are 8 projects that are an opportunity to an ACH, 2 of which are required. The 2 required ones are integrated care and opioid use. Optional projects include care transitions, care diversions. They include oral health, maternal and child health, and chronic disease management. Did I just list them all? I probably missed 1 or 2. But include a variety of optional projects. Importantly, how we're measuring success against these projects, since this is an incentive program, not a grant program, is by leveraging the common measure set. And in so many respects, the work of Healthier Washington is fully infused into the Medicaid demonstration project and will be going forward. In terms of further work of this group, I would absolutely encourage folks who have ideas around how HILN can engage in this latter process that will be occurring around project selection to act as somewhat of a statewide feedback forum and for both local decisions that are being made around project selection, as well as considering the statewide impacts or cross-regional impacts of those decisions. So if there's interest from Teresita and others more broadly to engage that in future HILN meetings, I think we would definitely try to make a way for that to happen. Teresita, I hope I got that close to the intent of your question, and if not, I'm sure we'll have time to follow up and maybe in our further dialogue period that's upcoming. So I think now I'm formally and officially turning it back over to you, Dorothy, to take us through our commitments to value.
All right, so the last part of this agenda is going to be a little bit of a setup, and then all about you guys helping us put some more meat on the bone. Is that the right? Yes, that's the right term for what we're moving forward with. So first, this fundamental change in how care is delivered by implementing models that drive towards population-based care, and I think based on what we've all been talking about today, it's the outcomes that we can get when we have measures of total cost of care based on the population served, measures of quality based on that same denominator, and measures of health. So just to keep us all really grounded in this concept, it's when you're in a fee-for-service payment world, you don't have a denominator that you can then measure the overall quality improvement for the population served, the health improvement, or the total cost of care. So just as a reminder, when we say we're driving towards population-based care, that's why. It's so we can actually learn and measure and improve by being able to specifically identify different populations and what makes the most sense in customizing care and services, whether they're in a medical home or in a housing center, wherever patients are, that we know where they are and what they need. So based on that, I think we're accomplishing this through this concept of, while we're focusing on populations, putting the people and the families at the center of those of that concept, so that while you're measuring a denominator, so to speak, you're really focusing on each and every person and their specific needs at the center of that. The incentives, these are really focusing on financial incentives in this slide, although I'd really be interested, and I know Bill would be, in what other kinds of incentives there might be. But in this case, it was incentives for purchasing, the consistent measurement that I just mentioned, the social health sector and how that works with everyone else to achieve the goals that we're mentioning. Equity, which was brought up earlier by Diane as a key construct. We need to note provider support. Bill mentioned that, so did Hugh. Others have as well. We haven't touched so much on the concept of the technology that we can use to really innovate care delivery models, service delivery models, if you will, but that's obviously something we also have at our fingertips. The data systems that we need to continue to build, obviously the working together, you know, this meeting itself and this team represents. And then last but not least, at the very center of all this has to be evidence-based practice. I know Teresita mentioned that earlier in some of her written comments. If we're doing all of this without a base underneath it of what seems to work and we can continue to build that, we won't be as successful as we will if we do. So we have all of these levers, and I guess got to say again, thank goodness we're in Washington State, because these levers relate to payment, purchasing, delivery of care, but also some other concepts as well. This value-based roadmap that we have here is one that you've all been familiar with. Nathan just alluded to these targets. I'm not going to dwell on the specifics there as much as I am if we're really focusing on the delivery of patient-centered, high-value care and improvements in quality as well as health and financial outcomes. We need that population base from which to do that work. We at the state level, because we purchase for a little over 2 million people in the state, are very intentional about rewarding the Medicaid and PEB plans and delivery systems for doing a great job on performance. I will mention here, I don't think we've actually specifically mentioned this, but that common measure set that we have in our state that was developed with people in our state has proved to be a very important anchor for this work going forward. We'll probably, as our work evolves, those measures will also evolve. But when we have that anchor and we can see the results of those common measures with the work the Alliance is doing for us, it's really important. So the standardization based on evidence, improving the long-term financial sustainability of our programs. Obviously, that goes hand in hand with what Bill was referencing earlier. The sustainability of the purchasing design is every bit related to the sustainability and vitality of those delivering services. And then continuing to this striving for better care, smarter spending, healthier people, and obviously the quadruple aim that's been mentioned with the addition, we don't want to forget about those systems and services that are helping to provide services for our populations. We need to make sure that that aim is also included. This roadmap and the numbers that are on here, as we continue to assess where we are as a state, those numbers will be adjusted, and we'll have somebody was asking earlier if we want even more interim goals along this roadmap for either Medicaid or the commercial population. I think we'll be working to moderate, measure this along the way, and we'll be continuing to evolve this. And if we need more interim goals, I think we'll put those out there and be interested in what people think those might look like. Okay, the next slide. This is also a slide that it should be familiar, hopefully, to folks. And this is directly related to the slide that you just were looking at in terms of the value-based roadmap. We have worked really hard to align the work in our state with the work of the Center for Medicare and Medicaid Services, who has an alternative payment model committee that has been working on this alternative payment framework. I have the privilege of sitting on that committee, and this, just like the roadmap will evolve over time, this actual model is being evolved as we speak, and I've been working with a smaller subgroup of this national committee to add in some additional categories or concepts within Category 4 that relate to the ongoing integration that we're seeing in our state and across the country with integration of delivery systems with financing, so that people are able to really grab hold of both the dollars and the delivery at the same time to continue the innovation. So we have been working really hard to align how we're measuring. Rachel Quinn is leading this effort for us, and so you may have all been talking with her at different times to make sure that we're measuring how we are along the lines of our roadmap, but also how we're matching up with the Center for Medicare and Medicaid Services work. You may have a question about whether or not this framework will be changing given the change in administration. I can say that so far that is not the intent of the new administration. They're very supportive of continuing forward with these alternative payment models. We may see some more additions to it, but we have not been hearing any signals that this framework will change. I think everybody's recognizing nationally that we have to use our dollars in smarter ways to get to the outcomes that we want. Yeah, and Nathan, do you have a comment?
I just wanted to add, too, that this framework has been embedded in the Medicaid transformation demonstration as well, and is what will define value-based payment for purposes of our targets under that 5-year demo. And so CMS is double exposed to this in our case, both through their national Medicare efforts, but as well our Medicaid demonstration, which was the first to land this framework as a part of it.
And just to add one more comment to that, Nathan, thanks for that addition. I had the opportunity about a month ago now to present what we're doing in Washington State to this land committee relative to this framework. And it was extremely well received. The comments were, how do we get what you're doing pushed forward in other states across the country? So there are a couple of other states, to Nathan's point, that are beginning to kind of catch on to this. And so I think it's another sign that nationally and state we're trying to align what we're doing to continue to kind of reinforce this model, but also to add to the literature about what we're finding and what evolutionary evolution might need to be added to this as we go forward. Okay, so that's just a little bit of a setup for Bill. I'm going to turn it over to you to kick us off with the next part of our discussion.
Thank you, Dorothy. Well, so the exciting thing about this is it takes all of us to make this happen. And there's the grid that's showing up here shows there's a policy role, there's a payment model roles, there's clinical practice transformation, there's measurement reporting. If you can't measure it, you can't manage it. And then there's consumer engagement. I'd actually say there's consumer responsibility as a part of this as we go forward. So we each have a role to play as we try to create the future of a healthier Washington. And it's public sector, and it's private sector, and it's social sector, it's delivery system, it's the payers. I think about value-based purchasing, even in my own organization. If a payer isn't willing to offer a value-based purchasing contract, it's hard for us to execute a value-based purchasing contract. It takes two of us to make that happen, and I think that's evident throughout the model we have here. I enjoyed reading some of the stuff that has been prepared by each of those of you who provided information. Many of us are actually working on advancing value today, and in different ways, in very interesting ways. I like the word cloud. It kind of gives you a sense of all the different ways people are thinking about what we're working on. This all came from the pre-work question: what action are you currently taking to fulfill Healthier Washington's commitment to value? You can see that in the detailed responses which Laura sent out yesterday, that you can read these, and these showed up in all kinds of different ways. I thought the observation that someone made earlier that there really is kind of a coherence, a consistency in the language that's being used was really positive there. We have integration of physical and behavioral health. There's value-based purchasing contracts starting to be ever more prevalent. Payment and delivery models are changing. We have advancement of a flexible and team-based workforce that's coming online in various ways. Engagement of community, all of these were common themes within the responses to that question. Many of you are actively engaged in specific Healthier Washington efforts, from supporting practice transformation, Support Hub, and the Accountable Communities of Health. I know my organization is currently working with 2 accountable communities of health, and about 60 days from today, we're going to be working with 3 over in Eastern Washington. And there's a uptake in the Healthier Washington payment model. So lots of interesting work going on. Sometimes a story tells it better than just speaking in generalities. And so each one of you has a different way of looking at this. We know that Michael Erickson with Neighborhood Care Health has some really interesting things going, and he's agreed to talk briefly about what his organization is doing to advance value. So, Michael.
Yeah, let me thank you, Bill. And if some of you had a chance to read the documents or have them available, and if you look under the clinical practice transformation, you'll see my comments there. So let me just quickly highlight a few. One is, and again, we were the beneficiary of some federal HRSA dollars to get started with expanding opioid treatment. And because of the unique position we have in both Seattle and King County, this is a very pressing need for us. And so we're expanding not only because we have new legislation that allows APPs, nurse practitioners, PAs, to be included in Suboxone prescription. We're literally training all of our primary care workforce to be capable of taking patients that would benefit from this kind of treatment. Corresponding to that, because they come in with other needs from our delivery system, it is embedding primary care, behavioral health practitioners in the primary care setting so that a primary care physician can literally step out of the exam room and have a behavioral health person down the hall to bring into that session and begin to determine what mental health or chemical dependency additional supports that would be needed. So those are 2 of the fundamental things that are happening on the primary care side. Because we are one of the largest dental providers to the Medicaid population in the state of Washington, we're now flipping, both with Qualis Health and others, to think about not only what is dental quality or oral health quality that needs to be advanced beyond what it is today, which is there a treatment plan and is it be executing? What does oral health quality actually look like in the next iteration? So we're involved in defining that. But more importantly, because we have thousands of dental visits, how do our dental practitioners actually know that a patient may have a care gap, either defined by the 9 core measures that Dorothy and team have framed for us, and what's the role of dental in being able to activate that patient and potentially address that care gap using the dental visit as the platform to do that. So those are some of the very specific opportunities in the short run. The other thing I would say, just in broadly, I've been doing this work now for well over a decade, first with Group Health, then with Palo Alto Medical Foundation in Northern California, and now coming to an FQHC here in the Seattle area, is really to transform the primary care practice to really be not only a visit-based capable of addressing care gaps, but all the necessary outreach activity that does not require a visit and a care team around that to help us achieve our triple aims. I'll make one brief comment here. Just Nathan sort of called it out when he was talking about alternative payment models. We were not able to agree in the July timeframe to go into APM4, the next alternative method. And why that is the good news story of having tremendous growth over the last 3 years in the double digits. but has also required us to chase a visit reality in the denominator to make sure we can be financially successful. So this is the absolute right direction for all of us to go in, and we want to get there as quickly as possible, but we find ourselves with one foot on the shore and 1 foot in the boat that's leaving the dock on this APM4, wanting to get there as quickly as possible. Have to get, interestingly enough, our visit rates up per population. Thank you, Peter Adler, for assigning all those Melina patients to us. But we have to get to a certain amount of visit activity in order to be successful in the PM world. So we still find ourselves somewhat straddled. But those are a couple of the activities that we are engaged in.
So, well, thank you, Michael, for that. It's, I learn something every time I have one of these conversations, and I'm going to steal a couple of these things already. So thank you for sharing that.
Please do.
Okay, so I liked your comment about 1 foot on the shore and 1 in the boat. I think that's a little more stable than a foot in 2 canoes. So think of it that way, Michael. You're stabilizing so you can move forward. Really. So
I may need advanced yoga experience in order to stretch those.
Yeah, that's true. That's a good point. Okay, well, that'll just help with all the, healthy living stuff that we all have to do as part of our population health. Okay, so we're going to spend the rest of the meeting now in an open dialogue about what those concrete and specific actions that you all are planning to take in the next year to meet our value-based targets. You can see here on the screen some examples from the work that many of you did ahead of time, and thank you again for that. And some of the detailed pre-work responses that Laura sent yesterday afternoon. And actually, I want to stop here and recognize the work and the leadership of Laura Zeichkin and her team. It's been remarkable to get us to this place, and I just didn't want anybody to think that this work didn't go on without a tremendous amount of the professional leadership that Laura and the rest of the team puts into it. So Laura sent those documents yesterday. We're hoping to hear from those who submitted action via the pre-submission and those who have yet to document what their specific actions are. As Bill noted, some of us have a lot of this in our heads, and we just weren't able to put it down in writing yet. So we want to spend some time doing that. So our goal is that everyone on HILN walks away from today's meeting with an action they may be taking individually, and also to have that sense of a collective action. I'm thinking, Laura, just checking with you that the result of all this work will be reformatted and reframed into something that's more integrated overall set of actions. Is that right?
That's correct.
Okay, Laura says yes, I'm right. Okay. So this will help us to form that comprehensive agenda that we'll see in the July meeting. So just before we get started again, reminder that your line is unmuted. Place yourself on mute when you're not speaking. If you find it more easy to just send a note to the webinar folks that you want to say something, we're sitting right next to each other, and we will catch your questions in that way as well. Just so you guys know that. So you can see from the slide that we still have up here that HILN members are doing all of the things that we've identified as a group that are necessary to move us forward. There are HILN members that are adopting alternative payment models, using the statewide common measure set, engaging consumers via technology and shared decision making, contributing data and analytics expertise to community efforts, getting the social health sectors engaged in health systems transformation, supporting our care teams and clinicians and moving to value and team-based care. They've been all structured around fee-for-service, and they need to move as well. And then considering how we can advance equity through both measurement and payment, as well as through the delivery of services. So I'm curious if there are any reactions. We've said some already to the responses that we've already gathered, or if leaders who submitted anything ahead of time wanted to expand on their submissions. We'll keep this slide up for a bit, and at some point we'll transition to live capture so that you can see what else, if people have additional commitments that they just want to take advantage of the time here to have them documented, we'll be doing that as well. So first of all, are there any overall responses to or reactions that haven't already been articulated to the work that you do see? I see so far that Hugh Straley has a comment. Hugh, go ahead.
Thank you, Dorothy. Well, I wanted to mention that the BRE Collaborative has just recently completed an implementation roadmap and a survey of hospitals, medical groups, and health plans. Paul Gruen was our consultant and spent the last several months. This work was sponsored by you, Dorothy, and the Healthcare Authority. And this report is now available. It will be sent to you and to other stakeholders. But it really outlines what are the key enablers and the barriers to implementation, particularly of the BRE recommendations. And I think some of the learnings were no surprise, but there were some surprises about the importance of some of the barriers. One is that there still is not a definite business case for many of the providers. Hospitals and medical groups spoke of that. And then the requirement for investment of upfront measurement. But at any rate, I think we would love to have an opportunity for the ACHs to look at this report and have a discussion about it. I would love for the HILN to look at this report and understand what its ramifications are. I think it's an important piece that Healthier Washington can benefit by. So this report will be coming up next week, and we'll be, as I say, sharing it with the BRE Collaborative at our meeting next Wednesday.
Oh, thanks very much, Hugh. And we've made a note that this discussion around this would be really helpful at the next HILN meeting itself, as well as with the ACH folks in addition. Really important to name the kind of things that are moving forward and the things that may be slowing down the work that we're doing. So really looking forward to seeing that. Hugh, just a point of clarification, where will you be publishing that? We'll just make a note. So can we send a link?
Yes, it will be up on the BRE website as well. I think if Jenny is on the line, she can confirm that. But and we'll be sending it to you for any other publication. But it will be on the BRE website.
Fantastic. So we'll make sure that folks on HILN receive that as soon as it's published. Thank you very much.
And the additional thing is what I mentioned. As soon as we can get also information about implementation in the ACPs, that will also be a nice part of our overall view for what are the barriers and enablers for implementation.
Okay, and we've made a note, Hugh, about that as well. Just as a follow-up to that, I know Dan Leslie's been tracking some of that work. We do have some really early returns on positive movement in terms of the process measures now for quality, that the ACPs are doing a really nice job of making improvements. But I think to your point, we should be almost ready to publish some of those early returns, keeping in mind that it's early. But that's we made a note of that as well.
Great. Well, you'll receive the report on Monday.
Okay, fantastic. Thank you. So I've got Nancy Gento and then Joe Rozak.
I want to pick up on a comment that Bill made earlier about the plans, commercial plans, and I know that the product we're working here is a work in progress. We're noticeably absent from any commercial plans, commenting here. And one thing I find, the Alliance works a lot with purchasers through a purchaser affinity group and other ways. When we talk with commercial carriers about are they offering value-based plans, they tell us they are in very high percentages. And I think that the definition, we would benefit in our community if we came to a common definition around models about what that meant as we're reporting. Because oftentimes I think what the commercial carriers mean are narrow networks. And I think many of them are making great strides. I don't mean my comments in any way to downplay the work that they're trying to do, but I think we would benefit if we agreed when dealing with our health plans what the definition is for the models that we're measuring, and have that as the basis for the conversation about how well we're doing.
So for those of you that maybe couldn't hear Nancy, I'm going to summarize a really important point, which is the Alliance works with commercial plans who report a very high % of their contracts being in value-based models. And the question then becomes, how are we defining that? And that the more we can even be more specific about how we're defining value-based models, that the better off we're going to be in terms of how to measure that progress going forward.
I think, Dorothy, it also helps those purchasers, you know, the private purchasers who have no argument about the importance of value-based purchasing. They just don't know quite how to do it.
Right.
And are looking to the plans to create those products that they can make available to their employees.
Yeah. So the added-on comment, which is, you know, in the spirit of everything having to be connected here, as we want purchasers to create the requirements for their payers to do more value-based contracting. They're wanting to do that, but they want to know exactly how to make that work. And I know there is just some beginning work with that. I don't know if Steve Mullen is on the phone or not, but I think you're making a really important point. And just for those of you on the phone, I'm seeing Rachel and her team who are here trying to oversee that definitional work and the tracking, nodding their heads in agreement. So duly noted as a really good suggestion.
Maybe we can take as a further action item out of that further discussion with HILN on the survey instrument that we will be rolling out to a broader universe of payer and provider participants, and the intent is to capture broad marketplace activity in this area and to do so within the definitional bounds of the HCP land framework with some further guidance attached. I will be honest, in prior efforts we've done them twice. It is still hard, even with definitions and even with parameters, to get everyone singing off the same sheet of music. It'd be great if we could leverage HILN to make further progress this time around than we've been able to make the last two times. So we'll take that as a follow-up item.
Great. Okay.
Yeah, I have a question. If we knew for the survey, like a baseline of where we're at in terms of VBP so far.
So the question is, have we done a baseline to date of where we are with the VBP? Rachel, we we'll repeat your answer if you have a short answer for us.
I'll take it.
Oh, Nathan's by the mic, so he's going to say it.
And I meant to address this because Sybil asked the question earlier and I screwed up by not addressing it.
Yeah, he was supposed to.
Sorry, Sybil. I apologize. We have done those two surveys, and I will just say finger in the wind wise, and what we hear from our plan and provider partners is roughly 20%. That is where we believed that we were baselining from in 2016, and this is with using the definition of value-based payments that we're pulling from the HCP land framework, and starting not with pay for reporting or not with narrow networks, but where there's an actual payment that is tied to quality performance of some kind or quality improvement of some kind. I'll be honest, that is finger in the wind and very, very highly variable by system and by payer. So I hope for 2017 purposes we'll be able to give you a more confident metric. And for certain, I would add to, for our books of business that are direct state purchasing books of business, on the Medicaid and PEP side, we are committed to providing and will be providing very explicit VBP rates from those contracts where we have direct oversight. It's really more a question for HILN as to whether we can broaden that out beyond state purchasing contracts. That's our hope.
Okay. Joe Rozak had a comment or question.
Yeah, thank you. It's more of a conundrum because of my agency is currently subcapitated and at risk. We essentially meet the definition for the top tier of value-based purchasing. Yet, so therefore, I need to, I guess, think inductively, and I need some help in doing that. Exactly Perhaps the previous questions would be really helpful as coming up with a common definition towards value-based purchasing, and how or where do we need to go next if we are where we think we want to drive most of or the rest of the, or 80%, as I guess we would be included in the 20% of those that are already at value-based purchasing to some degree. So can you help me understand or give me some direction on the road ahead?
So let me just see if I understand your comment and your question, Joe. If you're already, is your question that if you're already in that 20%, what's the next step?
Yes.
Okay, so maybe the simplest answer to that would be we should talk with you and see kind of where literally you are and what you're thinking you want to do next, and see if that's something we need to add into our evolutionary payment models. Not knowing just off the top of my head right now exactly what you're doing, just to be honest about it. I don't know that we can answer that specifically, but we've noted it as a question to get out and publicly respond to everyone on the call.
Thank you.
It's a really good question. It's a really good question. Yeah, Diane in the room has a comment.
So for us in our union, we come at this, I think, in what we consider a really exciting way. So our universe is, we represent 30,000 nurses and healthcare workers throughout the state of Washington that are in public, private, we start, we have people in PEP, we also have people in commercial insurance, and we have members in employer self-insured, healthcare employer self-insured plans. And we have a keen interest both through our mechanism of bargaining health benefits to make this a top priority, because obviously our members want quality and cost-effective plans. So I've just been thinking of some potentially new initiatives that we could put forth through the collective bargaining process. At the same time, our members touch, I don't know how many, tens of thousands of consumer patient lives, work with. And one of the things, and sort of this is with my public sector hat on, and we've talked a lot about this at the HCA and PEP meetings, is that we really have to do a better job, I believe, in educating consumers on how to use health services and what are the appropriate care at the right time, and nurses obviously do a lot of patient teaching, discharge planners, as we think about the continuum of care, not just hospital-based care, but home care, that healthcare workers have a tremendous role to play. So I'd really like to think about some initiatives that we can take as developing some best practices.
So I'm going to repeat Diane's comment, and I think Bill has something you wanted to say. Okay, Diane's comment was that given her role with collective bargaining, she's thinking of, number one, some kind of exciting ideas of how they could help leverage this work going forward. And then secondly, tied to that, and this is just parenthetically something that the Healthcare Authority has identified as a top priority as well, is to really keep moving that needle with patients and consumers. And I'm looking at Nancy in the room, and the Health Alliance has also been doing some work on this, to really help people understand when they're choosing their plans what constitutes that best value for them, and how we can get our healthcare workers fully engaged and knowledgeable about that, so then as they're talking with people that they serve, they can help spread that word. Did I get that right? Okay, so Bill, you had a comment?
Yes, so two quick things. One, to build off of what Diane just said. On the East Coast, there's a men's suit store that says an educated consumer is our best customer. And we have huge opportunity in that space. It will be very transformative if we can get to that in society. So I agree with you, Diane, on that. So I wrote a note to to Dorothy earlier that, we're not the only people looking at health status and ways to get to a healthier community. I don't know if people know, but the nation of South Korea has articulated a national goal to be the healthiest nation on earth. And their reason is because it's a sustainable competitive advantage if you're a manufacturing nation. Because if you don't have to have 18% of your GDP that flows into your products, it's a sustainable competitive advantage. And sometimes I think as we're doing this work, we ought to reestablish why we're doing this work. I mean, so it's a healthier community, that's true, but people get to choose some of that. So there's other whys, and some of those whys engage people differently. And I always like to start with why are we doing this work? I mean, it's really important work, but we engage people with why before we engage them with what. And I like all the what I've seen in what I've been reading, but also I'm interested in why are each one of us doing, what motivates us to this? And there's more than one important reason why we do that. So.
Yeah, really, really good point. I'm just thinking that this educating consumers could be a really awesome HILN strategy that we could all contribute to very concretely and specifically. Really great idea. Okay, Janet Varon on the phone has a comment. Hi, Janet. You may be on mute.
Janet, you're self-muted, so if you hit the mute button on your phone, you should be able to speak.
Okay, well, we'll wait, and feel free to interrupt me, Janet, as I'm talking if you're unmuted. I just have to say for the record that the concept of unmuting oneself is hilarious to me. It's kind of like self-editing, I guess. Okay, any other comments from the phone so far? Any other ones on this? Just really specifically, we've been hearing from many people about what they would like to contribute specifically, because if they hadn't had a chance to send something in ahead of time. Are there any other folks that have? Yes, Bob Perna in the room.
We talked about the leadership that's shown through the participants through the HILN, and we've also touched very briefly on Manette and its role in consulting. As we learn these lessons and find effective models going forward, to what degree is there a component of reproducing those models in the broader community? Is that part of the role of the healthcare authorities and that? How can that be helpful to them?
So Bob's question, and for those of you that don't know Bob, he's from the Medical Association. His question is, to the extent that we find that these models, whether it's through the accountable care programs or the HILN or the demonstration project, that these models are successful, what's the strategy and the process for sustaining them moving forward? I think, and then we do have, you mentioned Manat as one of the consultants we have on the Medicaid piece of this. I think that just to answer it very concretely, the intention is to continually share early and often results that are somewhat reliable, so you don't want to be out there going, oh, well, we're just doing more stuff. But that to the extent that we're showing some successes, then we would be wanting to not only publish those, but share them in a consultative way with anyone that wants to use them. I would say that would not only be on the HCA to do that, but if Bill's finding a really cool model that you've signed up for doing value-based delivery that works, we would want to be able to publish that, what they've learned, etc. So I would actually see that, you may not have been saying this, but as another concrete HILN activity to share those results and be able to continue to have a compendium of what's working. Just as an aside, I'm thinking also Nathan and Laura, who are beginning to plan the symposium for October, that this would be some of the really good concrete work that we could share with some of those early results.
And I was thinking about it also from the standpoint of sustainability by the originating organization, but also reproducible by other entities.
Yeah, right. So the sustainability not only for the original models, but the reproducibility, which is how we're going to get the spread, which is a really key point going forward.
And this, to add, was a fundamental commitment, actually, that we made in the State Innovation Model Grant application originally, is to span far beyond the state purchasing capacity over time, and we've, I think, always viewed and are trying to figure out then now the right levers to pull for this body and this group, HILN and broader, to make that actually happen. Several things that have been done related to the contracts being posted on the website, for instance, for the Accountable Care Program. The non-proprietary components of those contracts are one way we're trying to achieve that. And then I was going to add to the Medicaid demonstration through its evaluation and through required reports and through things like the MVP action team, moving the VBP parts forward. We are absolutely laser-like focused on dissemination and spread, not even just within the state, but I think even broader than the state geography.
Thank you, Nathan. And one thing that I've learned with, it's sort of like translational research in a way. You know, the way you structure this work has to be done in a way, to Nathan's point, that you can reproduce it easily and not have to go and reinvent the wheel. So really, really important point. Okay. Other final comments on things? We have I think time for one more kind of overarching question here before we're heading out of time. But, oh yeah. Oh, who is this?
Hi, Dorothy. This is Janet Varon. I'm sorry for the glitch
hi,
earlier.
No problem.
Okay to chime in now?
Yeah, absolutely.
Yeah, I just wanted to, and this is, apologies for the delay, kind of following up on Dan's thread about educating consumers. I mean, I think there's also an important area here for hearing from consumers and not just getting feedback, but also trying to actively incorporate their experience with their healthcare and outcomes into every aspect of value-based payment. I don't see a connection, a very strong connection yet between the financial incentives and connecting them with the experiences of individuals who are receiving care. And I just think that needs to be greatly strengthened. And we need to think about ways to do that. It's obviously more challenging than some of the measurements that form the basis of VBP now, but not something that we should shy away from.
Okay, thanks very much, Janet. It's that ongoing challenge and really key piece of ensuring that everything we're doing this has the ultimate impact that we expect it to on the folks in the state that we serve. So thank you for that. Okay, is there any other, before we go to the final piece of this about next steps, any other overall comments you want to make about this? If you still have things that you haven't been able to share today that you want to add to the commitments or the ideas that you have, please feel free to continue through the mechanism that Laura offered earlier to add in your thoughts or comments. Are there any other final thoughts or things that we've kind of fundamentally missed in this discussion before we go on to the next steps? Laura.
This is Laura. Something that I might offer that piggybacks, I think, on our broader conversations of value today and Janet's comment is that we have been talking with last year's co-champions of some of the accelerator committees that HILN put in place as subgroups of our broader leadership network. One committee that has really engaged champions and members is the Equity Committee, and we are exploring with those co-chairs and with the committee as a whole how we might put almost a toolkit or recommendations or somehow make actionable infusing equity into payment models and contracts through measurement, through incentives, and that's something that we would actually like to bring back to HILN at a future meeting.
Okay, so that whole topic, getting more specific again and bringing that forward. Thanks very much. I had a couple, there are some actions that we pulled out of this that were really cool, I think, for HILN overall action. So we'll add what Laura just said to those other thoughts that were, things like health literacy, understanding implementation barriers, sharing reproducible results, etc. But let's now, I think, because time is not our friend today, I guess we need to move on to next steps. Can we put that slide up even while you guys are entering? Awesome. Okay, thank you. So I guess what I would like to say is that we now have pretty good framework for that action agenda, and as we mentioned earlier, we'll be using our July meeting to get that finalized with those measurable steps of progress that we want to use. And also really important, I think, is a symposium in October. You all should have that on your calendars already. I'm thinking that's going to be a pretty awesome meet up for the whole state to see how far we've come with this. That's October 18th and 19th at CTAC. That's 2 days, and you can pick and choose one or both days. And then January 19th is our next overall meeting at Cambia Grove. So I'm going to turn this over to Bill for final comments and remarks.
Okay. Well, I want to thank everybody for spending the last 2 hours. It was a great turnout online and great participation. It's hard to do a conversation like this sometimes when you're remote, but I think it worked well, and I appreciate all of the good thinking and the good participation. Like I said at the beginning, this is an awesome group, and we can help reshape health in Washington in ways that should be a model for the nation, and I'm really excited about being a part of this with you. There is some action work. I'm going to call out other health systems, including my own, that we did not show up too well in putting our commitments into this document, so I have to finish my piece, and I would invite others of you who that might relate to do the same. If the shoe fits, wear it is kind of the attitude there, and it fits me today. I'd also like to thank those of the team who made this possible. Great prep for a program today and a conversation today, and more good conversation to have, moving from rhetoric to realities, from rhetoric to results, and I think that's a great journey for us to go on. Where I really don't want to end with this, but I'm going to end with this, is that there is going to be a change at the state that I am sad and disappointed about. I got recruited to a co-chair role, and then my co-chair called me and gave me some very sad news. So my experience is only 3 years in the state of Washington, but from the very beginning, Dorothy was open and receptive and engaged, and she worked with things inside multi-care when we needed input, and she engaged in helping our physicians understand going to a different future. What we're working on here is actually a big part of the vision that Dorothy created. We're in a waiver that's really unique in the states. We have accountable communities of health. There's a whole legacy that Dorothy has built during her time here, and we are going to really miss your leadership. And I, for one, feel abandoned, but I wish you the very best in what you choose to do going forward. Washington is better for your leadership, and this group exists because of your leadership, and I want to extend our thanks as a group to you for your leadership and what you've helped create here.
Well, great, and thank you for that. And abandonment is kind of a tough word, so just for that, you can expect to see me if I get an invitation to the symposium in October. Got
We'll have an
to make sure
invitation.
that we're keeping
Well,
on
do
track.
tell us where you're going, please. Yes, what's the news?
You know, I've just made the decision to step down as the director of the Healthcare Authority. That's not to say I'm out of the world of health systems transformation. It seemed like a good time to do that, and based on today, I got to say I feel like the state's in good hands to keep this work going, and you'll probably see me showing up in lots of different places.
We will miss
After
you.
a little bit, after a little long summer nap.
The most beautiful part of the
country.
country.
That's right. So thank you.
So anything else for the good of the order before we close the line and go on to what we hope is a beautiful weekend? Okay. Thank you, everyone, for joining today. Look forward to seeing you again in July.
Thank you.
Thank you.
You.